So I am Kathryn Emerick. I'm a perinatal psychiatrist, and I'm the co-director of APAL, which is Arizona Perinatal Psychiatry Access Line. I'm going to talk today briefly about Zuranolone, which is a new treatment for postpartum depression. Before we get into talking about Zuranolone, I want to talk just very briefly about why we would need a medication to treat postpartum depression. So PMADs, which are perinatal mood and anxiety disorders, which include postpartum depression, are the most common complication of pregnancy. So they occur in about 1 in every 5 people. And for comparison, preeclampsia occurs only in about 1 in every 25 people. It's really frequently untreated. For postpartum depression alone, 60% of postpartum people nationally are never diagnosed, and 50% never receive any treatment after diagnosis. So we know that this is an issue that is really common and is frequently not treated. It also comes at a really high cost. So there's cost to the mom, including risks of miscarriage, hemorrhage, hypertension, suicide, poor attachment, poor nutrition, breastfeeding difficulties, and struggling to manage their own health. And I highlighted suicide on this list because maternal suicidality is one of the leading causes of maternal mortality in the first 12 months postpartum. And maternal suicidality is very correlated with postpartum depression. There's also significant risk to the baby, including risks of preterm birth, NICU admission, low birth weights, and then also difficulties with attachment, cognitive and motor delays, and emotional behavioral issues. In terms of just dollars and cents, there's a huge cost to the community. So the average cost per affected mother-child dyad is about $32,000 a year. And that's estimated looking at the loss of economic productivity, the costs of preterm birth, and the cost of other maternal health expenditures that you can imagine looking at the risk to the mom. If we're talking specifically about Arizona, we're talking about a number that's greater than $400 million a year. So we know that this is a really costly problem, it's really common, and it's frequently untreated. And that is part of why it's really important that we have an effective treatment for postpartum depression. So a company called Sage Therapeutics came on the scene in 2019 with a medication called brexanolone. I know this is not Zuranolone, but we're going to get to Zuranolone. So brexanolone was the first medication that was FDA approved for postpartum depression, and it got approval in 2019. It was really exciting because it was this novel mechanism targeting this one specific suspected pathway of postpartum depression. And the data for brexanolone was really exciting. What we were seeing was really rapid improvement of severe postpartum depression, as well as improvements in sleep and anxiety, which are frequently comorbid with postpartum depression and are also risk factors for developing depression. Unfortunately, even with this really interesting data, there were significant barriers to care. So barriers to access included things like costing over $30,000 for a treatment, the risk of sedation to the point of loss of consciousness that they saw in studies, and then also issues around separation of the mom and the baby, because brexanolone was only available as a 60-hour IV infusion in the hospital. So because of all these issues, from 2019 to 2021, less than 500 people nationally received brexanolone. And to put that into context, in Arizona alone, the number of people that are impacted by PMADs would be about 16,000 people a year. So this would only cover a fraction of the need in Arizona, much less looking at all of the states in the US. So this is where Zuranolone comes on the scene. So they went back to the drawing board and they came up with this medication called Zuranolone, which got approval from the FDA specifically for postpartum depression in August of 2023. And just as a caveat, how they defined postpartum depression in the studies is as onset of depressive symptoms from the 3rd trimester up to 4 weeks postpartum. It's only approved for use in the postpartum period, but the onset of the depressive symptoms can actually occur anywhere in the 3rd trimester. Zuranolone is very similar to brexanolone. It has the same mechanism of action, but the difference is that it's bioavailable, meaning that it can be absorbed if you take it orally, and has a much longer half-life. So those were the issues with brexanolone. It had a very short half-life, so it had to be a continuous infusion, and it was not bioavailable, so it needed to be IV. So these changes meant that Zuranolone, very similar to brexanolone, could be taken daily over the course of 2 weeks in someone's own home. In terms of the data on Zuranolone, here is a chart from one of the studies looking at Zuranolone, and you can see very similar data to brexanolone, particularly looking at how fast the onset of improvement was. So we're starting to see a significant separation from placebo by day 3. We really have very few medications in psychiatry where we can see rapid improvement like that, and certainly not the other medications that we have for postpartum depression. You can also see that even beyond that 2-week course of medication, there continues to be a separation from placebo. So even though the medication has been stopped at day 14, people are still feeling better. So we know that this medication seems to work. It's still not entirely clear how long it's going to work for, because we know that definitely by 4 weeks after the last dose, by 45 days out, there's still significant improvement compared to placebo, but we don't know many months out what that looks like. Also, what's interesting about the data for Zuranolone is that SAGE looked at getting approval for major depressive disorder, so looking at just a general depressive episode. But what they found was that unlike for postpartum depression, the impact that you saw for MDD was really minimal and kind of fizzled out after a few days. After initial improvement, it didn't last. So this is really important for perinatal psychiatry, because what this indicates is that there is a specific pathway, there's a specific way that postpartum depression is working that seems to be different than other mood episodes at different times in people's lives. This is what people in perinatal psychiatry have long suspected. This is really interesting data that supports that. In terms of how Zuranolone works, it has the same mechanism of action as brexanolone. They're very, very similar. And neither of them are really drugs. What they are synthetic analogs of a naturally occurring neuroactive steroid called allopregnanolone. So allopregnanolone naturally modulates the GABA-A receptor. The GABA-A receptor is the same ones that benzo is attached to. And we've known for decades that this is involved in anxiety, mood, and cognition. What we also know is that the level of allopregnanolone naturally rises during pregnancy and then drops in the postpartum period. And it seems like for some moms with postpartum depression, it's that change, not necessarily that people with postpartum depression have a greater absolute reduction in allopregnanolone, but something about the sensitivity to that change results in symptoms of depression. A question a lot of people have is whether or not Zuranolone is a benzodiazepine. Because if you work in prescribing medications, your ears might perk up when you hear GABA-A receptor, because we always associate that with benzodiazepines. So Zuranolone does bind to GABA-A receptors like benzos, but it binds to a different part, and because of that, it has different effects. So Zuranolone has a much broader effect. It has both synaptic and extrasynaptic effects. And particularly, it's those extrasynaptic effects that create that difference. So in extrasynaptic GABA receptors with delta subunits, and there's like dozens of GABA subunits, but specifically the delta subunit is not sensitive to benzodiazepines, but it is sensitive to allopregnanolone, meaning that Zuranolone can have activity there. Over the long term, benzodiazepines downregulate GABA receptors, and that's how we understand the tolerance, dependency, and the potential for abuse. But Zuranolone, because of that extrasynaptic effect, actually ends up upregulating them. So you don't have the same concerns with Zuranolone that we might have with prescribing benzos. In terms of side effects that they noted in the studies, Zuranolone was generally well tolerated and much better tolerated than brexanolone. The main side effects that people experienced were drowsiness, dizziness, and diarrhea, but they saw no loss of consciousness in the Zuranolone group like they saw in the brexanolone group. Of note is that there is still a black box warning on Zuranolone that people taking this medication can't drive or operate heavy machinery for about 12 hours after taking the dose of the medication. And that's why it's recommended to take it in the evening. It's also important, given the side effects of drowsiness, dizziness, and the side effect of confusion, that no other sedating medications or drugs are on board. So if someone had a C-section, you want to really make sure that they're not continuing to take opiate pain medication. Also want to make sure that they're not taking alcohol, they don't have other benzos, they aren't using any other sedating medications, they aren't using any other sleep aids. In terms of how to take Zuranolone, essentially it's a standard dose of 50 milligrams taken every night for 14 nights. It's a really simple prescription. You can use a lower dose of 30 milligrams in the setting of severe hepatic impairment or moderate renal impairment. What we're also seeing practically is that if you have a patient who has really, really significant drowsiness, sedation, you may also get some benefit from reducing it to that 30 milligram dose. You take it every evening, around 8 p.m. is what they use in the studies. If a dose is missed, so if someone forgets to take a dose, you don't make up that dose. You don't want to have more than 50 milligrams in a 24-hour period. So you just continue with the next scheduled dose. The other thing to know is that Zuranolone has to be taken with fat-containing food of at least 400 calories. So things like avocado, eggs, or full-fat yogurt. So that fat is needed in order to ensure appropriate absorption of Zuranolone. The other thing that I think is important to know is that Zuranolone can be taken with an SSRI. So whether someone was on an SSRI during pregnancy and they're continuing it in the postpartum period, that's not a contraindication for starting Zuranolone. And you can also start Zuranolone with an SSRI. So that's not a contraindication either. The only caveat I would say with that is that if someone is naive to SSRIs and you're starting both of them, if there's significant side effects, it might be difficult to know what is causing those side effects. But in terms of safety, you can start both of them together. In terms of medication interactions, that's important to look out for. Like I said before, you want to make sure there's no other sedating medications that could increase that risk of confusion or sedation. Other things to look for are whether there are any other medications that are strong 3A4 inhibitors or inducers. So Zuranolone is primarily metabolized through CYP3A4, and it may be useful to run a drug-drug interaction check to make sure that you're not going to either run through or metabolize that medication really quickly, or you're going to inhibit the metabolism and you're going to end up with a much higher relative dose of that medication. It's also postulated that Zuranolone might have an adverse effect on early fetal development. So it's important to talk about birth control with patients that are taking this. They need to either be abstinent or in birth control for 21 days. So the 14 days of treatment and the 1 week after, to make sure that there's no potential exposure, fetal exposure, intrauterine exposure while someone is on Zuranolone. And then people also have questions about breastfeeding, where we're talking about postpartum people. So with breastfeeding, that's something we still don't have a ton of data on. And so the risk is kind of unknown. And right now the FDA is recommending against breastfeeding while taking the drug. We have limited data on sort of the risk for an infant, but there also, once we even get that information, the risk around sedation is going to remain a concern. So even if babies tend to tolerate Zuranolone very well, or the exposure to Zuranolone via breast milk very well, moms are still have the potential to be really drowsy or be sedated. And so the risk of breastfeeding in that state is still something really worth talking about with patients, because we don't want to increase the risk of accidents or suffocation occurring. In terms of data on infant serum levels, there is some data on the 30 milligram dose, which shows a relative infant dose of about 0.35%. That's really, really low, so very minimal passage into breast milk. But what we don't have information on right now is the impact of that dose. So we know that a really low dose tends to be safer, but even at really low doses, some medications have big impacts on infants, particularly newborns who have different abilities to metabolize drugs. So it's not a complete contraindication to breastfeed while taking this medication, but you really want to talk with your patients about the information we have and the information we don't yet have. If your patient is not going to breastfeed while they're taking the medication, but would like to continue breastfeeding after, the recommendation is to pump during those 2 weeks to maintain or even establish supply if this is really early in the postpartum journey. Other questions people have is whether it works for bipolar disorder. Does it work for bipolar depression? Does it work for anxiety? And essentially, we have very limited information about bipolar disorder. So bipolar disorder, depression with mixed features, was not included in the studies on Zuranolone. And we know that also it didn't get approved for anxiety. What we do know is that there was no mania induction in the trial. So we didn't see mania occurring in the trials. And given its mechanism of action and its sedating properties, we would not suspect that Zuranolone would likely induce mania. But right now, we just don't have that information. Now, let's say you've thought about Zuranolone, you have a patient in front of you who's a really great candidate, and you're thinking, yeah, I want to prescribe it. In terms of really practical steps, the way that you prescribe Zuranolone is that you send it into a specialty pharmacy. You send that 50 milligrams once a day for 14 days prescription to a specialty pharmacy. And you can call this 1-800 number, 844-987-9882 for up-to-date pharmacy information about where you can send it in. Once you send it into the specialty pharmacy, those pharmacies will help a patient access any available cost savings. So Sage has programs for commercial insurance, people with no insurance, people who are functionally underinsured, people with Medicaid. And so overall, what we're hearing is that cost is somewhat variable, but there's reports that people are getting the medication at no cost or at a normal prescription copay cost. So it seems like this is going to be extraordinarily more affordable than Brexanolone. The other thing to know is that if medication isn't in patients' hands within 10 days of the script being sent to that specialty pharmacy, if the insurance company is taking a really long time to get prior auth completed, if the patient's not able to afford it for some reason, then Sage, right now, at least at the time of this recording, will cover the entire cost of the medication. So that answers another question that a lot of providers have, which is if I have someone in front of me who I want this medication for because they need really rapid improvement in their symptoms, when I send that medication, is that going to take weeks and weeks to get approved in order to get that medication into my patient's hands? And what we're seeing is that no, it looks like the maximum delay is likely going to be 10 days because of Sage's current program. So hopefully you are walking away from this brief presentation with a greater understanding of Zuranolone, how it works, things you really want to be considerate of, and then how to actually prescribe it and get it into your patient's hands. If any other questions come up, if you have a patient who has questions that you're not sure how to answer, you have more questions yourself, please always feel free to give APAL a call. We're happy to do a case consultation. We're happy to answer any questions and help you walk through this process.